Scariest professor y'all have ever had. Okay, the hip, lots going on. Whole bunch of fun, happiness. We've talked about ligaments, right? How many ligaments do we primarily concern ourselves with in regards to the stability of the pelvis itself? 4, right? So what are they? Inguinal. I like inguinal. So inguinal is this first one right here. It's a good one to remember because we will talk about it more today as we go over the femoral triangle. So the inguinal ligament, ASIS. So find your belt line, your belt buckle, and then right below is pubic symphysis, and it's kind of running between those two. Okay? So straight across. Now notice that on each of these, what was the term we were talking about? Katniss, right? So every one of these is it's very much an archery set on each one of those. You'll find that these ligaments are helping stabilize that bony archway to help make sure that it's assisting the containment of whatever is in it, the lesser versus the greater pelvis, right? But it's helping create the tension, much like the plantar fascia does, to where these bones can't be pulled back apart. That we don't have the leverage to undo the archway. So inguinal is the first. You want to see the spelling? You can write it. Good. There's their bilateral. What else can we see from this view? We can't see all of it from this view, sort of now. There we can see. Iliolumbar. Good? So, goes from the ilium, the iliac crest, over to the transverse process of L4, L5. Lumbar 4, lumbar 5. Vertebrae. So this one's less about, this one's a little different because it's less about kind of stabilizing that archway and more about anchoring into and providing support to the sacroiliac joint. Stabilizing that iliac crest, that greater pelvis, up into the lumbar spine where we don't have excessive shifting. Okay? All right, give me another one. Good, so sacrotuberous. Sacrum to, what's the other landmark? Ischial tuberosity. So the tuberous is telling you it's a tuberosity of some sort, and then the big one that we have is really ischial tuberosity. Easy one to remember. Plus, you can kind of see that it goes there. All right, so give me another one. There you go. So sacrospinous. So the sacrum to the ischial spine. Cool. 1, 2, 3, 4. Now, stabilizing that SI joint, we have 3 ligaments, and those are crazy, simple, easy. And you can actually put that iliolumbar again within that SI joint category. But anterior SI ligament, and then there's an upper and a lower posterior SI ligament. Sacroiliac ligament.
Wait, iliolumbar was L4, L5, or what's that?
Yeah, so you're right there. All right. What motions do we have at the head? How many degrees of freedom?
3.
3. What are the motions we have?
Flexion, abduction, subduction, rotation.
Good. So all 3 planes: flexion, extension, abduction, adduction, and influential rotation. Good stuff. Where do you want to start? Flexion, extension, probably a good place because we've already talked about a lot of the things that do those motions. Okay, so flexion. Hip flexion, lifting the knee up, bringing it in. So give me one muscle. Give me a starting point. What do we know? What have we already gone over? Stop. hip flexion. Right? Hip flexion. So what's the first muscle we've already talked about that flexes the hip?
Quad.
Not all of the quads. Rectus femoris. So we got to get specific because 3 of those muscles don't cross the hips, so 3 of those muscles. So it's no longer that group that does it, it's rectus femoris. What is the origin of rectus femoris? It's hamstrings. AIIS. Anterior inferior iliac spine. So anterior inferior. So again, you can find it. Find ASIS, which is the more prominent. Go about a thumb width down and a thumb width in. So you're going diagonally. And there's a deeper bump right there. And usually when you're finding those bumps, it's the least comfortable place to push them. So it's right there. And then it runs straight down from there to join the quads. Across the hip. So let's get them up. Let's find some prettiness. Yay, muscles. Oh my gosh, I get to beat all these in your head. Yay. Okay, so that one is going to go away. And we'll do those two. And that one. They can all go away. Alright. And we'll come back to you. Good to go. Alright, so ASIS, right up in here. And so about a thumb width in, that way, and a thumb width down, kind of that arcing right through there, we get AIIS right there, making that rectus femoris. Excellent. Good times. Revisiting the old days. We have one more muscle, which is kind of actually a pair of muscles together, called the iliopsoas. I-L-I-O, so iliac crest, ilium, kind of makes sense. So the ilio, and then psoas is P-S-O-A-S, psoas. And we apparently dropped the P somewhere else. Iliopsoas, okay? Now, there are 2 separate muscles on origin, for sure, but they have a common insertion. They're both hip flexors, so they get run together as a common muscle of iliopsoas. So iliacus is the first, and again, iliac crest, so it's really simple to remember. And conveniently, the muscle fills in that entire iliac crest. I mean, the entire inside of the crest is that iliacus muscle. There's nothing else there. So all that landscape that we get from the inside of that pelvic bone, boom, we got it. No big deal.
So the iliopsoas
It's made up of 2 muscles. Iliacus is the first, and then psoas major is the second. So psoas major is this other guy that comes down with it. So you can see how they kind of blend in together into the lesser tuberosity right here. So straight line and pull it down to grab that femur and pull it up. Now the fun part is seeing where this comes from. So, that muscle right there. Good, good. So, you're seeing this come off the transverse process, the transverse process and the vertebral bodies of the lumbar spine. So it's actually connected to the spine that's helping pull this leg up. Now you have this sitting in front of it, coming off higher up into T12 or L1. Is psoas minor. Now psoas minor is a funny little guy because it kind of stalls out. If I grab him, you'll see where he's at. You'll see how he's grabbing into the rim right here of the pelvis, into that issue. And the pubis bone, sorry, as it comes down. Which would make it a very weak, like, tilting the pelvis. Trunk flexor, maybe. It doesn't do it. We don't want to talk about it much. Usually it'll attaches in funky places. We'll leave it be. Certainly not acting on the hip because it's not crossing the hip joint, so we'll drop it. Okay, so iliopsoas, iliacus and psoas major come in together on that lesser tuberosity. They function with the rectus femoris in creating hip flexion. So if I have a fully extended knee, so we had that lovely question on the exam that was showing a seated calf raise. And the seated part means that that knee is bent. So anytime we have a 2-joint muscle and we put slack on it by shortening one of the joints, then it's going to somewhat inhibit it because it can't produce the tension it needs to. So likewise here, if I slacken the rectus femoris by straightening the knee, then it's not going to be able to hip flex as well. It's going to put more load into iliopsoas. If I want to isolate the rectus femoris more, then if I flex the knee and I put tension on the rectus femoris, then I can see how much more it's influenced in being tight or injured or problematic, or just general function. So, hip flexion. 0, so full extension, 0 to about 120 degrees. What kind of infield? Hard? Probably not. We only have bones bumping into each other. Firm versus soft? You can even try it. I mean, you're kind of pushing soft tissue muscle mass. Soft tissue mass is kind of stopping where you're going. So I'm going to say more soft than anything else. So if we flex it, then we want to extend it. Conveniently, we've done the majority of this already. So posterior view, ischial tuberosity sits right up in here. Sacrotuberous ligament, you'll find right there. And we have a stream of muscles coming down. What muscles are coming down? Hamstrings, 3 of the 4. So just like the quads, we have to clarify which ones we're working with. Which one do we exclude from the hamstrings when we're looking at hip extenders? Which one doesn't count? Biceps short hip. The short one doesn't count. Always got to exclude shorty. So, semimembranous and tendinosus, and then biceps femoris long head are all coming off that ischial tuberosity. And because they're starting there, they are powerful hip extenders. They have less action if I flex the knee. If I flex the knee, I put slack on those muscles, which means they can't produce the tension. So you find the good Buns of Steel movies, videos, whatever, and you've got somebody who's like on all fours with that knee bent, and they're doing butt extensions like this. Well, it's because that puts slack on all of your hamstring muscles because you flex the knee, and it isolates the last of our extensors, which is gluteus maximus. So maximus gives us a lot of that shape that creates the curvature of the butt. Very powerful, strong muscle. It comes off the posterior iliac crest, right up and through here, all the way down through the sacrum. So it's a very long pull. You will find with max, mean, and min that they've got such a broad range of origination points that they're going to work in a whole lot of different ways. So whereas iliopsoas is very much kind of a hip flexor, as I start getting into others in the hip, if I reposition you just a little bit, it's going to change the function of that muscle. If you're in an internal rotated state, it may externally rotate. So as we go through this, you're going to learn it, and then you're going to go to PT school, and then they're going to start tweaking that a bit, and then you're going to go, man, Dr. Fisher, you're such a liar. I'm simplifying to where we can compartmentalize, so I'm hoping not to hurt your brains. So some of this, there's a little bit of logic to where you can go, oh yeah, that makes sense. If my leg was excellently rotated, then my medial hamstrings are going to create internal rotation. If my leg is already internally rotated, then Well, it's going to be a different set that creates more internal rotation. Okay, so we'll try to simplify this, okay? So just have a little faith and learn it my way. It'll be good. No problem. You're fine. So hip extension. So the hamstrings very much, they come down. You put slack on them, they lose some of their function. Glute max. Awesome. Huge origination point, but you can definitely see how because of that many different directions of fibers running, that it's going to have multiple actions. Good? So it's going a lot of different ways. So it's actually going to be an abductor, very powerful hip abductor as well. We'll include it in that group as well, but for hip extension, it's going to be pretty significant. Recognize that the insertion of this muscle is really pretty unique. So if you look at the top third versus the bottom 2/3, the insertion points are different, which kind of helps delineate the fact that it has multiple roles. So it's this distal 2/3 insertion point that's actually going into the posterior shaft of the femur. So, insertion, upper fibers at the iliotibial tract, lower fibers at gluteal tuberosity. It has its own bone. Good? So, from that, it fires to powerfully extend even if the knee is flexed. That's your hip extensors. Nice and easy. 3 hamstring muscles plus glute max. Alright, so since we're here, we'll continue down this conversation. You have this lovely band called your iliotibial tract, IT band, that goes all the way down here. So the top third of the fibers of the gluteus maximus insert into that IT band, which goes down the lateral side of the leg. To the lateral condyle of the tibia, which is very close to Gerdy's tubercle. So we go back to the knee, everybody's favorite, we miss it. And it's dropping in right on top of that LCL. Oh yeah, ALL, sorry, anterolateral ligament. And just proximal to tibialis anterior. Now this is a burden for a lot of people because it's common to get a friction syndrome to where as the knee moves, it rubs across the bone and it irritates the tendon, irritates the IT band. Quite painful to run on, quite difficult, quite easy to resolve if you know how. It's very much related to a specific running gait style, so if I have somebody who has a history of that, we change your gait style and it goes away. Problem solved. Or just throw in a foam roller, everybody's best friend. Hurts like the dickens, but definitely loosens it up to where you have less pressure, which means less friction, which means that it feels similar. So, distal end, it's really kind of that insertion point of the proximal, the superior third of the glute max. But you'll notice that there's another whole set of that IT band proximally. So where your ASIS is, for about a little bit of a width of maybe 3 inches, going posterior along the back side of that crest, going straight down is a muscle called your tensor fascia lata. Let me give you spellings. We reference it as TFL. So by its line of pull, I mean, it's going straight down. It is purely an abductor. It is pulling that leg straight out as it grabs into that IT band, forming the main components of it, and again grabs that lateral tibial condyle and pulls it out for abduction. So glute max and TFL insert into the IT band. The IT band goes into the tibia, the lateral condyle, and from that we have abduction. See, abduction is about 0 to 45 degrees. You can go from here to about 45 degrees. And I think I forgot to tell you extension. So you get 0 to 30 degrees on extension. You might want to add that back. Okay. So that's two. So if I highlight them, that pesky arm doesn't get in the way. If I highlight them, you can see another muscle peeking out just underneath glute max. So if you find that posterior pelvic crest, that ASIS, and work your way backwards, that pelvic crest comes right up and through here. So where we go about 3 inches back with TFL, about another inch, and then drop down, you're going to find a little bit of a tender spot in there. That tender spot is pushing right into this window in between these two muscle pairs. So sitting underneath that is glute medius. So gluteus medius fills in that entire crest. The majority of it is covered up by glute max, but you get a little pocket right up in here that you can palpate. Muscle's very strong for abduction, but it's unique in its influence on our movement, because it's not so much about the abduction actively. So we're good with concentric versus eccentric. What is a concentric muscular contraction? What is the muscle doing? The muscle is shortening as it fires. So take your biceps, I grab something, I lift it, the muscle pulls, it shortens. That's a concentric contraction. Eccentric, it elongates. Easy way to remember it. Easy eccentric elongation. So that's slowing things down. If I'm catching a ball, like an egg, trying to cradle it, it's deceleration. So I'm contracting, but letting myself get overpowered. Glute medius really falls in line there. So yes, it's an abductor, don't get me wrong. But when I step and do a lunge, eccentrically it's preventing my knee from dropping across my midline, from crossing over that plane. So where we start seeing injuries is in runners, whereas running is applied to any given sport. That glute med is firing strong when we have a heel strike position in front of our body. Because if it's not firing, if it's not strong enough, not activated enough, then that knee drops in, which does all kinds of wonky stuff to the alignment, and the weak link breaks. So IT band syndrome, that runner's knee that we just talked about, that friction syndrome, a lot of that can be dealt with by stabilizing glute med. If it stays out, no problems. Patellofemoral syndrome, major issue. Frequently, if we stabilize glute med, that knee's not dropping in, we don't go into genu valgus. We don't go into that knee pushing medially, which leaves the track under the patella, which is that intercondylar groove, right? In line. And if it's in line, then it's a happy patella. If it's out of line, then there's a lot of pressure driving it one way or the other. So if I take the patella, hide it out, a couple of things I had about. Then you see that track right in through here. But if I drop that knee medially, increasing that valgus stress on it, then all of a sudden, that patella is going to be pushing really hard into that lateral condyle, which is going to make the cartilage under it really unhappy. So that patellofemoral syndrome very much is related to the knee position, but that knee position is stabilized at the hip. It's not about strengthening quads, stretching quads, hamstrings. It's about stabilizing the hip. And very much that falls back into glute medius activation. Okay? But of course, you can't stop there. Hide them out. Oh wait, that was glute med. I'm just kidding. So glute max, goodbye. Glute med, up along the iliac crest, goodbye. And sitting deep underneath we have gluteus minimus. And this guy tucks into the greater trochanter. That really big bump on the outside edge. So very good straight line of pull to abduct the hip. So our hip abductors, gluteus max, medius, minimus, and TFL. There's mud.
Like tensor fascia lata.
TFL, tensor fascia lata.
Oh, yes, okay.
Same thing?
Mhm.
Same thing. Easier to say, easier to spell. All right, how many degrees in abduction do we have?
0 to
45.
45, right? So 0 to 45. How many degrees of forward flexion do we have?
0 to 120.
0 to 120. How many degrees of extension do we have?
0 to 30.
30, good. Now let's go adduction. Take this thing back in. We're going to go 0 to 30 on adduction. So you can stay in here, 0, and then cross it over and in 30 degrees. There are 5 muscles that we're going to focus on here. So I'm going to dig a little bit, pull out a couple things so that we can isolate what we want to see. So what's this little muscle right here again? Articularis genu. Such a fun one. So genu is referencing the knee. Then we start talking about genu valgum, genu varum in reference to coxa varum, coxa valgum because they're opposite, right? Okay, so articularis genu, that fun little guy grabs that bursa and just tucks it out of the way when we move. When we flex and extend it. Fun stuff. All right, 5 muscles. We're going to start with the 3 in the middle first, because they all have an easy name that starts with the word adductor. Good, right? Okay. Most common, easy to find is adductor longus. Most superficial. And if there's a longus, there's probably a brevis. So sitting underneath, we'll find adductor brevis. A little bit more proximal, superior. And then we have the really big one called adductor magnus. Now all 3 of these are coming off. You'll see. That's not what I need. Come back. Origin, inferior ramus of the pubis, inferior ramus of the ischium, and tuberosity of the ischium. I mean, all 3 of these muscles are coming off of the ramus, which is kind of that webbing right in through here. I'm not going to ask you to differentiate one from the other in terms of origination points. So if you can give me that much. Where we start seeing a lot of these smaller muscles kind of overlapping in their origin, it's going to start trying to explain that difference in words, which it should, but you're getting to where it's becoming 2 sentences worth of explanation on the origin. Find a way to simplify it. When you work on your wikis, and I encourage you to, because it's going to slap you if you don't, put it in terms that you remember. Put it into pubic ramus, ischial ramus. Put in the term ramus, and then you can identify it because that's pretty much the only place we're going to see this. Okay, so try to find a way, the biggest piece, the easiest piece, to kind of truncate it, shorten it, that it makes sense to you. If you have questions or concerns, go, hey, can you check the wiki to make sure that we're right? Is this what you want to see? And I'll do that. Not a big deal. Okay? But I don't need you memorizing 2 sentences because that's not something that's going to stick. So put it in terms that you're going to hold on to. All right. But I want this back. Got it? Got it. Cool. Magnus. Magnus is fun. Big, big muscle. Kind of sits on the entire medial border of that femoral shaft. But then you'll see that there's a chunk that drops down to act on the medial epicondyle. Now, Magnus has a few things going on. It's actually referenced as having a hamstring part and an adductor part, to where it will work with your other hamstrings to help pull back. So it's coming off that pubic ramus. So it's got the leverage by grabbing just a little bit proximal to the semimembranosus insertion, and then which is a little bit proximal to the semitendinosus insertion. That those three together have the leverage to extend that hip as a hamstring would. Okay? The rest of it, though, or all of it in that regard, the adductor part, which is going to be this section and through here, is going to have a line of pull that way versus the line of pull that's more directly posterior for the extension. But the coolest piece is you'll see this adductor hiatus. Hiatus means passage, hole, right? So this big old gap that runs right through there. You want to take a guess? What goes in it? It's just for fun. Let me give you some arterial structures. So your femoral artery is anterior, and then it drops through that to go behind the knee. So it's kind of an important little passageway. Kind of, sort of. So it's about protection. It's about making sure this artery stays deep and hidden amongst all the muscles so that it's not getting damaged. Because if it gets damaged, then we have major, major issues. A rupture in this artery would definitely risk your life.
What artery?
This is your femoral artery. And we'll talk about it in just a minute when we finish up, because we'll talk about the femoral triangle. Good? Okay. So now these two muscles. So we had brevis, longus, magnus. Then we have one above and one below. So the one is kind of the wiry little guy. It's called gracilis. So again, off that pubic ramus, but dropping down into, dropping down into pes anserine. Remember the name of that location? So kind of that flat spot right down here below the knee, below the tibia. So MCL comes in, pes anserine is this flat spot medial to that tibial tuberosity. So what else inserts in that area? Sartorius does. We haven't talked about that yet. What else have we talked about that's there? There are three muscles that hit this spot. We remember them by the letters SGT. Semimembranosus is going to go into that groove for the membranosus right there, so that means it's semitendinosus, it comes down. So Sartorius, gracilis, semitendinosus, SGT. All right? We'll come back to Sartorius in just a minute. There's a reason I've kind of excluded him. So, gracilis, adductor dropping down below the knee. So that's the one below. If we dig up high, we end up with this guy right here called your pectineus. So, pectineus, adding for brevis, longus, magnus, gracilis. 5 muscles make up adduction. So what's left is internal external rotation, but I'm going to pause for a second so we can kind of divert and finish up because there's a muscle that I keep skipping. So I frequently talk about these guys as though, depending upon the line of pull, they all kind of do something fun and different. Sartorius just does a whole lot of stuff. So we need to kind of recognize it for its uniqueness. So if you find the ASIS, this spot right here, and coming off of that, it drops in an S shape, a curved shape. So it drops in a curved shape down into that pes anserine. So Sartorius starts with an S and just moves in an S pattern, S shape. And it's got three primary actions. It is a fair hip flexor, for sure. We remember, there's a test, we do a Faber. F-A-B-E-R. So, flexion, abduction, external rotation. So by where it sits, it certainly flexes. Because it starts lateral and inserts medial, it's got the leverage to abduct. And likewise, because it's anterior and has that motion, then if it's going to grab, it's going to externally rotate. So a cool little test to remember what it does is that if you're sitting here, and we want to test this muscle, test this sartorius, take your heel and slide it onto the shin of your opposite leg, and then just slide your heel up that tibia. So you are flexing, you're bringing it up, you're abducting because your knee is deviating that way, and you're externally rotating as you come up. That is your sartorius. It's called your Taylor's test. Why? I don't know. Taylor? Like son Taylor? Faber. Flexion, abduction, external rotation.
So when you ask us about like your abductor muscles, we don't include something.
I mean, I officially cannot count you wrong if you do. If I give you a multiple select that says, pick the ones that are in there, I probably won't pick sartorius unless I want you to consider asking. Okay. It'd be more like, what are the actions of the sartorius, and I'll give you a bunch of stuff and you'll pick those.
Okay.
But if I'm going to look to identify your knowledge of the primary adductors, primary abductors, abductors, because that's it, then probably not quite as much.
Okay.
Okay? Yes, it would be correct to include it in that list. Because I exclude it in how I group things, it would just be pretty jerkish of me to do that. Okay. And if I accidentally did that to you, you are, then it's probably a couple of recordings going on, you are in your complete right to come back and say, that was pretty jerkish if you do that. Then you go play that for the dean, and the dean's like, yep, he's a jerk. So we're good for that. We're all on the same page. All right. Cool. So external rotation is next. So to get there, we got to dig out some stuff because it's kind of deep. There you go. As soon as you get rid of glute max, you see this whole pocket of stuff sitting right up in here, tucked up underneath that sacrotuberous ligament and that lower SI ligament. Just for the fun of it, we'll get rid of glute medius too. Now you're in the Okay. So we're going to go high, low, and then we're going to go high and low. And then we're going to go in and out right through the middle. So let me explain what I mean. High, the top one. There we go. All right, so greater sciatic notch running right in through here. And we have this muscle punching straight through off our sacrum over to the greater trochanter. This is your piriformis. Runners like to get piriformis releases. Sprinters especially. So if I go and put muscles back on, you'll see it sits pretty much right in the middle of the glute max belly. So if you take an elbow and drop it right in there and just dig, tremendously fun and exciting. You can also take a tennis ball and do the same thing, where you kind of just sit back on it, and it's just driving a massage directly into the belly of the piriformis. Yes, it's going through glute max, but it's isolated. It's hitting piriformis quite nicely. So it's the upper. Now, something to pay attention to is its pathway through that greater sciatic notch. That greater sciatic notch, if you remember, that landmark is this huge opening right in through here. Anyone want to take a guess at what comes out of the greater sciatic notch? Where have you heard that word before, sciatic? Sciatic nerve. So let me go add in some nerves, and boom, you're going to see the huge, like on dissection, if you ever get the shot, this thing's the size of a pencil. It's huge for a nerve. Like, it's so cool to dig this one out. But it exits right out of that greater sciatic notch along with piriformis. So for the length of a nerve, for as many structures as it passes in, around, weaves up and down, whatever it's doing, a lot of these places, passing by bones, in between muscle sets, with fascia, they're restriction points. Nerves don't want to move much, but they need to move some. They need to have the freedom to give a little bit. And if we go in with sciatic nerve coming out of that greater sciatic notch, it just so happens it's not its own unique nerve. It's actually two nerves kind of squished together. They'll separate very, very shortly. So it's your tibial nerve and your common fibular nerve. And again, we'll touch this later, it's no big deal. But not everybody has them stuck together as it passes by the piriformis. So the timing of your body putting your Legos together as you develop, or your genetics and telling it how to pass. Sometimes that common fibular will separate from the tibial and go around the piriformis to where the muscle is actually splitting the two apart. Or sometimes a branch, that common fibular, actually runs straight through the belly of the piriformis. So you have a major nerve that controls a whole lot of your lower legs, sensory-wise and muscle activation-wise, movement-wise, and it's going through the belly of a muscle, so when it contracts, it's going to squish on it some. Again, that's obviously going to be a point that could be restrictive and lead to irritation in that nerve, which could be problematic. So when you look at piriformis, definitely pay attention to its presence in that greater sciatic notch. Do jumping jacks or something. All right, so that's high. We're going to go low. Low is down here. This is quadratus femoris. So quadratus means that, again, we're looking at its shape. So it's like a quadrate, rectangle. Insertion, intertrochanteric crest on the femur. So between the greater and the lesser trochanter, quadratus femoris pretty much runs and spans the distance. External border of the ischial tuberosity. Shorten that, just say ischial tuberosity. Get a rough idea where it's at and you're good to go. And again, I'm not going to sit here and try to differentiate my external rotators from each other on their origin. So, high, piriformis, low, quadratus femoris. Then we're going to go high and low. And the reason I'm going to group these together is because of their names. We have superior gemellus. And if there's a superior, there's probably an inferior. So that's the low. So we jump over that middle one, and we have inferior. So high is piriformis, quadratus femoris is on the bottom. Then we go superior and inferior gemellus. And the last dude, the last pair is obturator internus and obturator externus. So let's kind of clean some stuff up so we can see what we're talking about with these. just to put it in perspective that it's not a funky name just for the sake of it being a funky name. Okay, so that's obturator internus right there. I'm actually going to hide them away. Where you have all the ramus, the ischial ramus, the pubic ramus, into the pubic symphysis, we actually have this hole. So that hole at the base of the pelvis, right? That's your obturator foramen. Over it is the obturator membrane. And then on either side of that membrane is the internus, the obturator internus, obturator externus. So obturator externus means it's attached on the outside of that obturator foramen. Obturator internus is attached on the inside of that obturator foramen. And they both punch through right around the greater trochanter for insertion to assist with external rotation. Piriformis, quadratus femoris. Superior, inferior gemellus, internal and external obturator. Good to go? Cool. External rotation. 0 to 45 degrees. Internal rotation, 0 to 45 degrees. 90 degrees worth of motion between internal and external rotation. 0 to 45, 0 to 45, we're golden. Internal rotation. Semimembranosus and tendinosus are two of your predominant internal rotators. We'll kind of sort of leave it at that. Based upon the position of the leg, you're going to start playing in with glutes, with anacromagnus, that kind of stuff. It's very much a secondary motion that we have. But the medial hamstring muscles provide the principal strength, especially if you go into external rotation where you put some tension on them. They're very strong pulling it in. So I would say, actually, let me add adductor magnus to that list. You start looking at gait research, and you start seeing that our leg, anybody have an old pair of shoes? Old pair of shoes?
Mm-hmm.
Yes. Can you toss me one? So we'll talk gait in the near future. But if you look at somebody's heel and look at their tread pattern, it's usually on posterolateral side that you have your primary impact. So your leg is slightly externally rotated when you touch down. So we need to create that internal rotation to pull us back in. Part of that's driven actually by the position of the talus under your body weight. It starts that rotation back inward, but there's muscular activity between adductor magnus and semimembranosus that peak, that assist that pull. So best way we can kind of find that is, if you look straight on, you'll see that that's actually crushed down a little bit more so than the other side. Kind of to catch it to we're not tripping. You can learn a lot about people's movement patterns by watching stinky old beat-up shoes. It breaks my heart when an athlete walk in and you're like, let me see your shoe. It's only like a week old. I'm like, there's nothing to wear pattern. It's not fun. Go beat them up some more. Okay. So, flexion extension, 120, 30. Abduction, 45. Adduction, 30. Internal external rotation, 45, 45. Groups of muscles. Iliopsoas, rectus femoris. Extension, 3 of the 4 hamstrings, plus glute max. Abduction, gluteus maximus, medius minimus, and TFL. External rotation, high and low, internal, external. So piriformis, quadratus femoris, superior, inferior gemellus, internal, external obturator. And then internal rotation, we're going to do membranosus, tendinosus, and adductor magnus. Good. So let's put these things back in here because I want to show a landmark real quick. All right. From this view, you're going to start by identifying your ASIS. ASIS, find your belt buckle, just go below it, and you're going to go to pubic symphysis. So your inguinal ligament. Superior border. We're going to create the borders of a triangle called the femoral triangle. All right, from there, we're going to go adductor longus. And then we're going to close that off with sartorius. So that is your femoral triangle. Anybody have siblings, cousins, they're a nanny, they have their own kids? Go find one. I heard you had a couple blonde kids.
2 and 1.
2 of them. Okay, cool. Good to go. All right, so go find a kid, and most people, if somebody else touches you right here, you're tremendously ticklish. Like, oh my gosh, and you'll curl up. Most places we're ticklish are because your body is protecting itself and reacting to the fact that there is a nerve or something underneath that it doesn't want you to destroy. Such is the case with the femoral triangle. This is a tickle spot. Let me get rid of this so I can show you what's in there. Because there's a whole lot, so I'll put the triangle back on now. And there's a pretty impressive set of stuff right there. That's the femoral artery, femoral nerve, and femoral vein. I can actually go back in one more place and add in your lymphatic system because you have lymphatics running there too. We'll pull that out. So, the femoral triangle has the femoral navy. NAV, nerve, artery, vein. Very important when we come to emergency management. Somebody has a distal injury, we can't stop bleeding. This is where you go to apply pressure, try to help stent the blood, to slow the blood flow. If I want to assess somebody having a significant problem, if they have a decreased blood pressure, you can assess a little bit by trying to identify. If you can't feel it here, then you have major problems, because you can get a pulse there as well. Now, it is this hole. No, go away. I want you to move. There you go. It is that passageway underneath that inguinal ligament, the sheathing from the fascia that opens up for those vessels to punch through, that we start having issues with hernias where that small intestine can slip in that hole if it gets opened up along with those vessels. So it's because that passageway is opened up in the peritoneal cavity from the thoracic, from the abdomen down into the lower leg, that we have the ability to let some of the soft squishiness to slide through, unfortunately, which is going to create a bulge right there on palpation, if that so happens. Refer box, send it to somebody else. Let them deal with it. Not something you want to fix. Good? Awesome. So recognize, as some of you look forward to working football, this point right here, your ASIS, very prominent, very exposed. Football players like to hit things and get hit, or hit the ground, or whatever else. You can get a bone bruise. So you bruise that bone right there. It's called a hip pointer. It makes life miserable because of the number of attachments that originate or insert into that landmark. So you bruise that section of bone, football player or not, and all of your abdominal muscle, your external abdominis externus comes in and tucks in right in through there, and that crest along behind it. So breathing, crunches, extension, anything that pulls on your abs causes pain. Abduction from TFL coming down, yanks on that spot, so coming out that way causes pain. Sartorius originates on that spot. Comes up for hip flexion, abduction, external rotation, causes pain. So life is, and then on the inside of that crest is iliacus, right? Fills in that entire inside groove, which means that if it's deep enough, then you're also going to have issues with hip flexion there. So up, out, breathing, extension, ab crunches. Miserable little contusion. I think that is enough about hip for 1 week. I would strongly encourage you to spend 30 minutes today, walking through the groupings, the origination. You will be asked the borders of the femoral triangle. You will be asked the contents of the femoral triangle. I like groups. It makes for easy questions. It helps reinforce that you know the basics that the muscles exist. Learn your groups. Yes, ma'am.
Can you say the femoral triangle one more time?
Absolutely. So, inguinal ligament. So, ASIS to pubic symphysis. Sartorius. And adductor longus. And if you ever want to see a really good visual depiction of where this thing is, watch the movie Black Hawk Down, because one of the guys gets shot right there and it ruptures his femoral artery, and they're digging and digging trying to get it to clamp it to stop it. Yeah. I do not need to be a military medic. Hats off to them. Good to go? All right.